Hello, my name is TK Monzon. I am an outreach nurse working with Whittier First, and we are part of Gateway Connections, which is a collaboration with PATH and Our Place Housing Solutions, City of Long Beach, and Helpline Youth Council. I don't have their logos. This is also my first video and trying to work with this presentation, so let's see how that works. And let's start. Anyway, I want to do documentation basics. It's a training video to kind of get staff aware of, like obviously basics of documentation. We are homeless service management agency, so a lot of our interactions need to be documented. A lot of events need to be documented. This kind of covers what should be documented or some parts of it. We will go over more on like the type of documentation required or used in First Day and in later videos. I just want to keep this as short as possible. It'll be like 45 minutes. Just kidding. Anyway, documentation basics. Let's see. Oops. Starting off there. Start all the way back here. There we go. So documentation basics, I did all that. So yes, documentation, it is part of public services. So police department, fire department, doctors, lawyers, anyone who generally works with the public generally has some kind of form of charting or documentation. Excuse me, not everybody is a fan of it. I myself is not. In fact, I do whatever I can just to avoid it. By interacting with more clients, as a result, I have to chart more. It is time consuming, which depending on the type of charting, sometimes charting can take anywhere between 15 minutes extra. But you shouldn't be doing an hour of charting for every 15 minutes of interaction. That's just absurd. It does decrease a lot of your client interaction time because especially for billing services, we don't bill yet, or hopefully not, but for medical wise, a lot of you have, for doctors, they have 15 minutes of interaction and then they'll have to do about 30 minutes of charting, but they can only bill for 15 minutes of it. That also decreases a lot of other interface time with other clients, but which, that's why a lot of people go into the field that they are, because they want to work with people, but charting prevents that. However, having said all those things, it is really important. And for the matters discussed, the reasons why charting is important: one, it's an effective way of communicating what you've done with the client. If you, per se, it's also a way to access information. So if I was working with a client and all of a sudden I had the flu, knock on wood, and the next day I'm not able to go, and then the client comes in, it's like, hey, TK was working with me on getting a ID voucher, but he never really gave me the voucher. So my coworker can come in, look at my charting, and deliver the same kind of chart. Give them the paper to kind of continue the care. It also takes account of what I've done and what I've been responsible for. So if I've done something or I didn't do something, make sure I have to chart that. Things that I have not done or things that are not charted should be charted. It goes to the whole saying, like, if it wasn't charted, it wasn't done. And there's a lot of, it opens up a lot of problems and it makes a lot of things clearer. Quality and assurance, that's for more admin stuff. Continuity of care, so let's say if we were to hand a client do a warm handoff to another agency or to another services, we can kind of fill them in on what we've been doing with them over their time with us. It is evidence-based. In fact, a lot of our charting, a lot of data is pulled from our charting. And it also allows higher ups to kind of figure out or do some kind of policy change that benefits you or the client, or some kind of policy change that kind of inconveniences us. And that's why charting is important, because we want to make sure, you want to push back and say, hey, this is what works, or hey, this is not working, change it. It also establishes legality. We don't get sued. And there's a lot of cases where if something was not charted, and a lot of organizations and hospitals have dished out money or lost lawsuits and had to pay an absurd amount of fees because of charting issues or technicalities. Having said that, charting should be complete and accurate. Obviously, you don't want to just say have something and cut it off halfway and then start on a different charting. You have to try and complete it. It has to be accurate. You don't want to exaggerate, definitely. And you want to hold yourself accountable. That's part of the accountability part. You also want it to be charted in HMIS, obviously. So in our organization, our database, which is Homeless Management Information System, it's the electronic charting for homeless information, and it's countywide. So, which is a nice thing. And like in the hospital, it's the electronic charting, and each hospital has their own charting, and it's very siloed. The HMIS, it's more countywide, so a lot of other agencies can see client services that were accessed. I'm not sure if that's true because of the level of access. Anyway, charting should be done within 48 hours, at least in this field. In the hospital setting, you want it done right away. In a medical setting, you want it done right away because it ensures quality of care. So, for example, if I didn't chart something until like 5 days later, however, there's something that was important that the client needed, person coming in, another staff member can come and look at it, and all of a sudden, like, hey, something's missing, or hey, it wasn't done, and then they can kind of duplicate service, or may some kind of run into trouble, maybe deny the client of something of a service that wasn't discussed. It ensures continuity care, essentially. It has to be easy to read. So some people like to add in things that aren't relevant. So for example, like, client likes Skittles, and there's no really point to that. Why does that need to be in there? It has to also be professional. So you don't want personal opinions about client. So client is being stupid. I'm not a favorite of the client. Client is attractive, or client smells lovely today. Those are words or descriptions that are more opinion based per se. They shouldn't be in the charting. It really looks unprofessional, and hopefully, like in future videos, I could show you examples of it. It has to also be confidential. So you don't want to just broadcast this on YouTube or on Twitter or whatever. Some people do get to see your chart. Who are they? So internal staff, so your coworkers, because hey, they want to know what you've been doing for the client, so that way if the client comes to them, they have an idea what to do or what has already been done for you. Collaboratives, that's the same thing as internal, but more on a larger scale. So if you want to, you're going to refer to, let's say, Department of Mental Health, you may want to give them a report of what you've done over the brief period of time you've spent with them. Admin, especially, so you want to, it's more like what you need to improve on, i.e. like spellings, more accurate charting. It kind of lets them kind of coach you on to better effectively manage your time and your charting. Funders, definitely. Like I said, it's evidence-based, so they pull a lot of the data, and a lot of the data and the numbers, and the numbers may reflect on the amount of money that they want to fund you. So yes, that's why you need to chart. The client certainly does have the right to go to see their own chart and their own folder. I can only think of 1 or 2 instances where the client requested to go through their chart. And if everything is like, professional and confidential and everything, they don't have a problem. I don't know what exactly the policy is on ours and any other organizations, but I think the client does have a right to have copies of their own charting. The judicial system, we don't want this. Well, we do, but we also don't want this, because usually this means like we're being sued or there's some kind of legal action taken on us. And then lawyers will nitpick on, not lawyers in general, but people in the law system, legal system will generally nitpick your charting and kind of find technicalities in which a lot of hospital organizations have lost on. That's why it's really important to do these things, which are complete, accurate, timely, easy to read, and professional, etc. There are types of charting. So we're kind of going to go off on the medical social work. I personally have a background. My background is in nursing, so my charting system is nursing based. I'm not too familiar with, like, for example, fire department, police department, but they have their own charting. Flow chart paperwork is a type of charting. You see that an example is the VI SPIDAT CES paperwork. There's a lot of check boxes. It's an easy flow. You kind of pinpoint on what the client may need. From that data, you can pick out what the client needs from that. You have the narrative charting. Those are more point in time or events. There's several types. There's the SOAP, FDAR, and DOPE. We're going to go over those later. And then you have the narrative. So the narrative is more just brief, complete story. I worked with the client to do this. The client did this, blah, 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 blah. That tends to be more time consuming, very detailed, but time consuming. Staff here, some staff do work on a narrative. Myself really am trying to get it out of that habit. SOAP is more like subjective, objective, action, and planning. FDAR is focus, data, like your assessment, action and response. I'm not sure what this is. I'm not too familiar with this. I pulled it up in I Googled what are the most common types of charting, and these three came up. These are more familiar with. Staff in the past in first aid, we actually kind of work on this kind of model, the action planning, subjective, objective, action, and planning. They're not really aware of that, but it's more of this model. But it does have to, there are several, despite the fact there's a lot of different types of charting, there's several different components, each with the three. So they have kind of a generalized formula, which is assessment, planning, intervention, and evaluation. Again, HMIS, and I've kind of already touched up on that, it's the Homeless Management Information System, and then that's the countywide charting where we're going to need to chart. We also have Google Docs, and we'll also go over that. So the first part of basics of charting is the assessment part. There's two parts of it. There's the subjective and then the objective. Subjective data or subjective stuff that you collect that you want to write down, they're more non-measurable stuff that are subjective. So they're more like client feelings, what you heard the client said. So there are also actions reported outside of the occurring action. So like if you're sitting down with the client and say, well, yesterday I hurt myself, or yesterday I went to go fill up a job application. So those are the things that you want to include under subjective information. Also, you want to do client requests. So client requests a GR appointment, or client requests transportation to wherever for their appointment. Objective data, they're more measurable by quality or amount. They're observable at the time of interactions. So like they're basically sense-oriented. So sense-oriented or document-oriented. So that's the client produced a DD-214 and they were honorably discharged on 1971. I don't know. It's written, it's documented, and you see it. Other things is like the client has blonde hair. Client has a blood sugar of 356. Those are because you measured it. Those are things that that fall under measurable or objective. There are also stuff that you've seen or heard the client says at the time of interaction. Yes, it's kind of like what the client says. So kind of symptoms and actions, these two right here are kind of one and the same. If you have any questions I'd be more than happy to go over with those. Lastly, with the assessment, you don't want to go over diagnoses. You always want to reframe things as observables. So for example, client has bipolar or client has schizophrenia. That's a diagnosis. Well, you're not a doctor. How would you know that? And so what you want, you can actually get some nurses, they actually can get sued because they create a diagnosis. We are not allowed, it's not in our scope of practice to diagnose things. But we can reframe. So we can reframe by stating symptoms. Client stated that he's being chased by the federal government. Client states that he's being watched right now. Client feels that there's a little man that's telling him to eat more pancakes at 3 o'clock in the morning. Those are symptoms of schizophrenia or delusions. Clients thinks he's Jesus, or clients thinks he's David Bowie, and he's really not David Bowie. You don't want personal opinions. Again, you don't want to say like client is being stupid, or client is attractive, or client has nice biceps. Stuff like that you may want to leave out. That's very unprofessional / bordering sexual harassment. And you don't want to make conclusions. So for example, the client is drunk. You don't want to make that conclusion. Yes, the client is definite. Maybe you can see, and from your experience, yes, the client is clearly drunk. However, you want to reframe that into the symptoms you've seen. So the client smells of alcohol. The client is flushed. The client is slurring. The client has altered. Is not all orient and altered, and the client is stumbling. Those are the things that create a picture that indicates, hey, maybe this client is drunk. You don't want to ever say the client is drunk, the client is drugged up, the client, anything like that, that might bring some liability or slander. You also want it to kind of be focused, and we'll go over this in more videos later down the line about focused charting. An example of this is an assessment is this. And checkbox or flow sheets, these are you can just check these off and you kind of get an idea rather than write them out. It's very effective that way. You know, client, what the types of document the client has, where they're applying for, their criminal background, able to work and has not found a job. It also preps you kind of an ideas of it kind of sets up a platform of what you're going to have to do with the client. So so for example, here, you may want to think about, I'm going to plan to maybe refer them to a job club or some employment enrichment agency. Here is more of a focus assessment. It's not perfect, so mind you. This is specifically in detail about what I did with the client, or where I met the client, and what exactly I'm meeting the client for. So really, it's about the DPSS appointment that the client has, and date and time. Actually, it's a female client, so that's a mistake. And we'll go over that. And a quote. And quotes really bring a lot of what they say. You want to quote verbatim. You can paraphrase, and that kind of helps you have you and the other people reading your charting, a picture of what the client is going through. The other part of it is the planning. It's not often used in social services. It's more medical stuff, but because it's redundant. In a lot of the charting, you want to include nursing diagnoses or actual medical diagnoses, but really, because we're in a social services model, those are really not part of it. It is generally expressed as you're reading through the chart or charting narrative as a whole. So if you're going down and reading the client's events, you kind of have a picture of what's being done for the client. So you want to get an idea of what's to come. So dates and appointments of the client, the documents that the client may need to be addressed, and concerns and behavior overall of the client. So quotations, these kind of give you an idea of what to plan out and what to look out for and how to plan out your interventions. So for example, in that last right here, you want to go, the client needs transportation to El Monte DPSS at whatever date and time. Client is concerned about not wanting to leave their belongings alone in the camp. So that kind of gives you an idea, well, this is probably what's going to stop this client. So maybe I should focus on how to intervene with these to kind of allow the client to remove these barriers so that way the client can move forward with their goals. And you want to research distraction techniques to help the client. So in this example, because the client has anxiety, and you can tell them, hey, take your anxiety med, but you also want to research techniques for you to work with the client while there to kind of remove that barrier with them. So a lot of people, you can just be with them and sit with them, and that kind of helps. And you want to also kind of say, well, why does the client need GR, general relief, for? So, well, for income, for a voucher, for document readiness, those things. The third part of essential documentation is intervention. So what you've done for the client. This involves more of the verbs. Actions performed at the time of client interaction. So their patient teaching, any conversations you had with the client, any services that you performed for the client. So you transported, you gave them bus tokens, you gave them money for a deposit. You want to capture those in this part of the documentation, or this is the interventions that you perform. You make sure you have to, for everything that you interact with, you have to have like an assessment and then what you did for them. You want to be as descriptive, but relatively descriptive. So like, well, you're performing all these actions, and then you all of a sudden, you give them a tube of I don't know, a tube of icy hot, and that's almost irrelevant. Yes, that's a service, but why did you give them a tube of icy hot when you're transporting to DPSS? Did the client ever request a tube of icy hot, which is a muscle relaxant or something? Why is that even in there? You may wanna go back and kind of add to your assessment or planning why they needed that tube of icy hot. You want to be mindful of time frames. Their possessions, certainly that's legal. So like, for example, if the client they had their cell phone 1 minute and all of a sudden it disappeared, yeah, you may want to like document that part. Not always part of the case, but it's something to be mindful of. You also want to make statements and observations of the client at the time. So for example, hey, I'm coming in to do they actually observations at the time. So like, they came in and they were willing, and they were ambivalent about it. So they want to do more, they want to explore other options, or they refuse services. That's kind of, and you want to walk them through why, and you want to state why. Those are the kinds of things that would fall under this. An example of this is, for example, I picked them up in the location for their appointment time, who I transported with. That's certainly important because it kind of denotes that I didn't transport them alone. If I left this out, it usually notes that I transported alone. Also, having said that, you may want to also document. You shouldn't document for other people unless they were there. And in this case, let's say I was with a staff member, I can say, yeah, the staff member I was with this staff member. The staff member has the choice to document on their own and kind of have their own perception of the event that occurred, because hey, it may be different, or hey, maybe when you went to the restroom, they told them something important. What happened to their belongings, what you did, because of, like, for hit cat left with uncle in encampment. So you kind of suggest, you kind of help with what happened. You kind of help fill that gap of a problem. You also did some patient teaching. You kind of help what you really did for that client that supports your assessment and problems that you found that may be barriers. And after doing all that, you got to make sure, was it really effective, or did they help? Or if not, what did you have to do to adjust that? Or was there really an action performed? So for example, if in that case, we did transport them, what became of it? Did they get their GR? Were they denied? Did they have to do another appointment follow-up? Did they say that their ID was valid and therefore you have to start again on square one and do their ID? All actions here have an evaluated response, really. You have to make sure that for every action you do, there's some kind of evaluation that follows. So you're doing a lot of follow-ups with client, as is with case management. You're kind of making sure they're doing the right things, or if not, you want to adjust to accordingly. For example, here, well, when you transported, they ended up getting their GR. That's CalFresh and Medi-Cal. So that's more of a what happened to them. So what happened? How did it happen? How did it work? Client, and then you made sure that you didn't just leave them there and you transported them back. And then what they request in the future. So maybe they want their benefits, proof of benefits document scanned and an email to them, or they say, well, I like the way you helped me, and I want you to help me with other things. And so they request, hey, maybe I need help with my primary care, or hey, maybe you can get me into a shelter. It's not documented here, but I'm just giving examples. Maybe also the client requests money skills or saving plans, and maybe they don't want at the time, hey, they don't want to be referred to a job club yet, so they're not ready. So maybe you can include that. That's what's missing from this charting, and maybe you can add that in an addendum. So for example, like mistakes, addendums, and late entries, you never want to delete or scratch out a mistake if you're writing it. You just want to strike through with one line and initial. That kind of shows of legally, if you scratch it out or delete it, that's really actually, that is illegal. It won't be considered a legal tender or legal document. And it also shows that it implies guilt if you delete something or you cover something up and to a point where you can't read it. So you just want to strike through and then initial it, maybe even time it. And I'll show you an example. You want to date it, and addendums, stuff that you want to add into. So you want to, let's say like you forgot to add into something. So for example, in that, this one, the client, I forgot to add in, like maybe the client's not ready to do, the client's not ready for employment services at this time, or employment referral service, referred to an employment enrichment service at this time. If it wasn't charted, that probably means that, hey, I never really touched on it. So you see how that goes? And that's what an addendum is. I can add that in and say, well, client stated that not ready to for employment enrichment services at this time. And late entries, you can actually add, late entries should be added after 72 hours. And if they are, you want to document on a new portion or a new area. But you also want to say, quote unquote, late entry for this charting. And to show you, for example, an error, it's like this. So met with client. If you notice that I don't, in the quotes, like I don't want to leave my dog, I wrote that in. So it's actually a cat. So what I do is I just scratched out the dog, one strike through. I am on a mouse, that's why it's almost illegible. And then I put my initials. Addendums, you wanna, I might not do this. Addendums, this is kind of like, this is a DAR charting, and we can go over it. See, client, let's say client also wanted to do a substance abuse referral. I can also add in client not ready for employment enrichment program. Will follow up. And then you sign your name, TK Monzon, or title. Or if you have one of those fancy titles, like doctor or I don't know, Superman, I don't know. Yeah. So you want those kinds of, this is kind of an example of an addendum charting. Notice that on the date, I also need to have a time on there. It is actually 12:23. So, yeah. Anyway, so those are the kind. So going back, you want to make sure it's over 72 hours event. If you have any questions, let's see, you can't do them in here, but there we go. If you have any questions or comments, just email or find me. I will be everywhere, or find another staff who's more versed in documentation, which is everybody. And then this is just to like a brief introduction of new incoming staff. And if you want to refresh on what components of actual documentation is, we will go over actual policy, what we chart in, and I can go over in charts. Just email or questions, and thank you. Have a good day.